Okay, let's dive right in. We're tackling a topic today pulled straight from your revision notes, Acanthosis nigricans.
That's right, AN.
And it might, sound like it's just about skin,
Uh-huh.
but these notes really highlight it's often a pretty important clue about what's going on deeper inside the body.
Absolutely. So our mission here is to take these notes, your notes,
Hmm.
and really pull out the high-yield stuff on AN.
Make it quick, effective for revision.
Exactly. Help you nail the key concepts and, well, understand why they matter.
Perfect. So let's start with the basics. What is Acanthosis nigricans according to the notes?
Okay, so at its core, AN means you've got these thickened, dark patches of skin.
Second and dark.
Yeah, the notes describe them as symmetrical, kind of velvety in texture, sometimes like brownish plaques.
And where do they typically show up?
Usually in body folds.
Mm.
Think the neck, definitely the armpits, the axilla, and the groin area. Those are the classic spots.
Right.
And the notes immediately link this finding quite strongly to insulin resistance and potential metabolic issues.
Ah, okay. So straight away, it's positioned as more than just skin deep. It's a sign.
Precisely. It's a visible clue.
So what are the main causes then? Who's most at risk according to this material?
Well, the notes really hammer home the link with insulin resistance.
Which often means...
Often means obesity, type 2 diabetes.
Yeah.
Those are flagged as major risk factors. Huge connection there.
Gotcha.
But it's not just that. The notes list other possibilities too. Things like hormonal disorders, PCOS is mentioned,
That's right.
cystic ovary syndrome,
PCOS.
and also acromegaly or Cushing syndrome.
Wow. So hormonal stuff can trigger it too?
Definitely. And certain medications get a mention, like the combined contraceptive pill, nicotinic acid, sometimes even corticosteroids.
Okay.
And then there are less common links like certain GI cancers, hypothyroidism, some genetic factors, Prader-Willi syndrome is listed, and family history.
So quite a list. For revision, it sounds like. Remember insulin resistance first?
Top of the list, yeah.
But keep that wider differential in mind. Hormones, meds, the rarer stuff.
Exactly. It's a signpost, like you said,
Yeah.
but potentially pointing down several different roads.
Right. So how does it actually, happen? The pathophysiology bit in the notes.
The mechanism they describe is actually quite neat. When you have insulin resistance, your body kind of overcompensates, right? Pumps out loads of extra insulin.
To try and get the sugar into the cells.
Exactly. But all that extra insulin floating around, it doesn't just work on sugar. It also signals to skin cells.
Oh.
Yeah, it basically tells them to grow faster and also ramps up melanin production.
The pigment.
The pigment, yes. So more cells plus more pigment equals that thickened, darker skin we see in AN. High insulin makes skin grow and darken. Simple as that, really.
That's a good way to remember it. Okay, so we know what it is, why it happens, what does it look like in practice, the clinical features.
Well, you see those classic signs.
Yeah.
The thick, velvety, dark patches, usually, yeah, neck, armpits, groin, maybe other folds.
Just as described.
Right. The notes also mention you might see other things nearby, maybe some itchiness or skin tags, those little fleshy growths.
Ah, okay.
But, crucially, the AN patch itself, it's usually asymptomatic, doesn't hurt, doesn't usually itch much on its own. Its presence is the real symptom signaling something else is up.
The clue again. So how's it diagnosed? Is it just by looking?
Primarily, yes.
Right.
The notes say diagnosis is clinical, you see it, you recognize the pattern.
Makes sense.
But then the investigation part kicks in because you need to find that underlying cause, right?
Right. The why.
So that means blood tests, checking glucose, insulin, lipids, looking for those metabolic red flags, and maybe hormone tests if things like PCOS or Cushing's seem possible.
Okay, so diagnose the AMI site, then use labs to hunt down the root cause. What else might look similar? Any differentials mentioned?
Yeah, a few key ones. On the skin itself, you might think about melasma or post-inflammatory hyperpigmentation, maybe some types of dermatitis. They can look a bit similar.
Okay.
But just as important are the underlying conditions AN points to, like diabetes or PCOS. Those are really the differential diagnoses you're trying to confirm or rule out.
Good point. Don't just stop at the skin. Which leads nicely into management. What's the absolute key takeaway from the notes on treatment?
The number one principle stressed in the notes is address the underlying cause. Full stop.
Treat the source.
Exactly. So if it's insulin resistance, obesity, then lifestyle changes, weight loss are key. If it's diagnosed diabetes or a hormonal issue, treat that.
Makes sense.
Now, there are topical treatments, creams, and things that might sometimes be used to improve how the skin looks.
For cosmetic reasons?
Pretty much.
Hmm.
But the notes are clear. Managing the root cause is the primary goal and the most effective approach.
Fix the underlying problem, and the skin often follows. What does that mean for prognosis?
Well, it depends entirely on managing that underlying cause.
Yeah.
If you get the metabolic issue or the hormone imbalance under control,
The AN gets better.
often, yes,
Yeah.
it can improve significantly, sometimes even resolve completely. Better control underneath means a better outlook for the skin.
Okay. And complications. The notes seemed quite specific here.
Yes, very important distinction for revision. And in itself doesn't really cause complications directly. The thick skin isn't inherently dangerous,
Right.
but it's a marker, a warning signal. The real complications come from ignoring the underlying conditions it flags up.
Like the metabolic stuff.
Exactly. Uncontrolled diabetes, insulin resistance,
Mm-hmm.
that can lead down the road to serious problems, cardiovascular disease, kidney issues, poor blood sugar control. Those are the complications.
Right. So the AN is the alarm bell, not the fire itself. The complications come from ignoring the fire.
Perfect analogy. Early diagnosis and management of the underlying issue is absolutely key to preventing those serious downstream problems. Understanding AN as a marker is vital.
So looking back at this deep dive, what really stands out from your notes is how AN connects the dots. A skin change signaling major systemic issues.
It really does. Which leads to a thought for you to consider as you revise this.
Uh.
Given AN is often a signpost for significant problems like insulin resistance or diabetes, what does that tell us about the importance of noticing seemingly small changes in our bodies? How valuable is listening to those signals for catching bigger health issues early?
That's definitely something worth mulling over. We hope this run-through of the high-yield points from your notes has helped clarify things for revision.
Yeah, hopefully it clicked. And remember, for more resources, check out pastthemsra.com.
And freemsra.com as well. Thanks for joining us on this deep dive.